Good afternoon and namaskar to respected Professor Subhash Wagner sir, Professor Santosh Shavan sir, all the Naidaniki Organizing Committee members, respected faculties, Chairperson Dr. Aman Shirke sir, the speaker Dr. Manju Chandan Khade ma'am, and all the respected faculties, beloved students. I am Dr. Anna Misha, Assistant Professor in the Department of Rognidan and Vigyan from Parle Institute of Ayurveda. Welcome you all. And first of all, I wish you very happy Onam in advance. In our campus, we are celebrating the Onam today. And I'm here to say a few words about our organization, RVPGA, about us. Our organization, RVPGA, was formed in the year 2016 under the able and dynamic leadership of Dr. Subhash Wagner sir, with the aim to give the legal status of pathologist and radiologist to the PGs of Rognidan. Our organization is newly registered under the Societies Act of 1860 at Charity Commissioner Office, Nagpur. Postgraduate students, teachers of Rognidan and Biochemical can become our member. Ours is the only organization which is fighting for the lawful rights of Rognidan PGs. Even the NCSM had also directed State of Maharashtra to consider RVPG as a stakeholder in the constitutional pathology regulatory body of the state. RVPG is pursuing this matter with the state and central government. Not only this, RVPG is constantly pursuing the implementation of NCSM salary structure in all the private Ayurvedic colleges across the nation. All the communications are uploaded in our website www.rvpga.com. Our activities include regular conduction of online webinars and offline seminars both on national and international platforms. Hands-on training program for PGs at our partner NAPL accredited pathology laboratory at Mumbai, Nagpur and Pune. Publication of research papers of Nidan students and faculties in our peer-reviewed International Journal of Diagnostics and Research (IJDR). Interested can visit journal site www.ijdrindia.com. Edited book volume series through our international publications RIPI, which is registered in Government of India's ISBN portal. Those who want to contribute book chapter can visit RIPI website www.rbpgaiip.com. We do legal fight for the issues of Rognidan evam Vigyan PGs at appropriate forums. We have our YouTube channel and Facebook page where you can see our educational activities. Thank you, sir. Thank you so much.
Thank you, ma'am, for precisely introducing our organization. Now, I would like to invite Dr. Darshana Ubade, madam, to welcome our guest speaker.
Hello, good afternoon, everyone. Am I audible?
Yes, yes, ma'am.
Once again, hello, everyone. Myself, Dr. Darshana Ubade from Tilak Ayurveda Mahavidyalaya, Pune. We have started Naidaniki 2023 from 12th August 2023, in which we had lectures on basic diagnostic technology and diagnostic importance of peripheral smear. So today is the third lecture of Naidaniki 2023 web series, and for that we have our guest speaker, Dr. Manju Chandan Khede ma'am from Biochemical College, Nagpur. So on behalf of Rognidan Vikriti Vigyan PG Association for Pathology and Radio Diagnostics, I welcome you, ma'am. So I would request Dr. Dikonwar sir to introduce now. Over to you, sir.
Thank you, ma'am. Thank you so much.
Thank you, ma'am. Before inviting our guest speaker, I would like to your introduction. Dr. Manju Chandan Khede, madam, currently working as Associate Professor in the Department of Biochemistry at Biochemical College, Vana Dongri, Nagpur. Madam did her MBBS from IGGMC Nagpur and PG in Biochemistry from GMC Nagpur. Ma'am has vast teaching experience of 14 years as Assistant Professor. Also, she is a recognized PG teacher with permanent MOHS approval. Ma'am published total 20 research articles in national and international indexed journals. Also had 11 copyrights and 2 monographs. Now with this, I welcome and once again request to deliver her talk on subject.
Thank you, Dr. Ankush, for the nice introduction. Should I start sharing my screen?
Yes, yes,
Should
yes.
I?
Yes, yes, ma'am.
Is it visible?
Yes, ma'am, it's visible.
Okay.
Yeah, it's visible. It's visible.
And
So-
make, ma'am, please click the slideshow button.
Yeah, it's in the slideshow mode only.
Yes, ma'am.
Okay. So good afternoon, everyone. At the outset, I would like to thank you, Rog Nidan Vikruti Vigyan Association, PG Association for Path and Radio Diagnosis for giving me this opportunity to deliver the talk on biochemical parameters. Actually, this topic seems to be very easy and known to everyone, but as we go in practice, so this becomes very important to understand how to interpret the biochemical reports and what's the importance of that. Not only the interpretation part, but also the sample collection and the pre-analytical analysis is also important, but we will not go into the detail of that. In between, I will go on briefing that. So I'll be starting my topic on the interpretation of biochemical parameters. So thank you, organizers. So my first slide, it is on the regarding the introduction of biochemical parameters. And these parameters, they are the measurable substances in the blood and other fluids that reflect the physiological and biochemical processes occurring within the body. And they provide insight into the body's metabolic state, organ function, and overall well-being of the body. And they are the essential component of routine medical tests and are frequently employed in disease diagnosis, prognosis, monitoring, and treatment evaluation. Is my slide visible?
Yes, ma'am.
Okay. So it's not moving. Yeah. So in the coming slides, we will discuss some of the most critical biochemical parameters and their interpretation, which allow health professionals, researchers, and even patients to comprehend the implication of these measurements. And understanding biochemical parameters, it can empower healthcare professionals to make the informed decision leading to timely intervention and improve patient outcomes. Additionally, not only with the diagnosis, prognosis, researcher can also rely on these parameters to gain a deeper understanding of disease mechanism and develop effective treatment. So these biochemical parameters are important not only for the clinical diagnosis monitoring, but most of the studies, they are based on these research articles. Research it is based on the biochemical parameters only. So based on that biochemical parameters, we can say they are important for the clinical practice as well as for the research purpose. For the clinical practice, the most important thing is the diagnosis and monitoring of the disease or the prognosis of the disease. So biochemical parameters, they are important for the diagnosis of the various medical conditions, and physicians usually use these biomarkers to identify disease and assess their severity.
Madam, sorry for the disturbance. Just click on the screen and then scroll down so that my slide will move on.
Or otherwise, resume the slideshow. You click on the resume slideshow button, madam.
Okay, fine.
Because
Sir, now is it visible?
yeah. Better, madam. You click on the slideshow, madam. There is an option: home, insert, design, animation, and slideshow. Just on the top. Can you see that?
So I am already in the slideshow format.
And you are in the slideshow format, madam, but the slideshow has not yet started. Can you see the? Can you please check the top menu? Means home, insert. There is slideshow option. You click on slideshow.
Slide control is there.
Slides
after home, insert, design, animation. Then there is a
slideshow option on the top menu. Now there is a resume slideshow button.
Top ribbon.
Yeah, I am there. So I am trying again. Okay, so slideshow. There's saying some option is there. I'm not able to see that option. Share all sharing option. When you are Let me try it again. Slideshow from the no. So it's not working. So I am in the slideshow only, but it's still in your screen. In my
Okay, we are fine with it, but just make
It's
sure
okay,
that
ma'am.
the slide moves on. Just
yeah,
Just,
it's
just
moving.
go on clicking the slide.
It's moving.
it's okay.
Slide is moving now.
No, not.
You try to move. Just click on the screen and then scroll down.
Yes, sir. I'm doing that.
Just click on the screen and then
Yes, I click. Yes,
No, no. Bhagav,
no, then scroll down.
scroll down. Yeah. Actually, so that option is not there.
Madam,
Yes.
you don't share the screen now.
Okay, fine.
First of all, you do use on the
sharing.
PPT mode.
Yeah.
On the PPT mode, now you got the option home, animation like that on the top. Can you see that now in your PPT?
In my PPT, yeah.
Yeah. Can you see that slideshow option is there on the top? Okay.
On the top left hand side.
Right
Yes,
hand side.
there.
There, you click on slideshow.
Yeah, I am in the slideshow.
Click on the slideshow, and now on the left side, start slideshow. The option is there. Start the slideshow from the beginning, something like that. Yes, madam. Now it's clear. Yes, perfect.
And now it's viewing.
Madam, it's okay now. It's
Okay.
hello. Yes,
Sorry
madam.
for the sorry for the inconvenience. Let's start.
No.
Importance of biochemical parameters. So, as I said that these biochemical parameters, they are important not only for the clinical practice and also for the research part. And from the clinical practice, we can say that someone's mic is on, that's disturbing. So, for the diagnostic purpose and for the monitoring purpose, biochemical parameters, they are important for the diagnosis of the medical conditions, and physicians use these as the biomarkers to identify disease and their severity. I think that someone's mic is disturbing. All participants, please switch off their mics. Please mute yourself. Yeah. As I always give the example of blood glucose, we all know that increase in the level of blood glucose, the patient is labeled as diabetes. But if there is some issue with the labeling or in the interpretation of the report, I always instruct my technicians, my PGs, my juniors that while issuing the report, we check the values always, because it's sir, someone's mic is disturbing. Please mute yourself.
Madam, you unmute yourself now.
Yeah, am I audible?
Yeah.
So, for the diagnosis and monitoring, the for example is the level of blood glucose level which we all know that increased level of blood glucose, they indicates the diabetes mellitus. But if suppose there is issue in the labeling of the report, so that can happen that a diabetic patient becomes a non-diabetic and non-diabetic becomes a diabetic. And physicians, they are also dependent on our reports. So this part of the reporting is very important, that while issuing any kind of report, you should again and again recheck all the aspects, whether it's pre-analytical, whether it's analytical, whether it's post-analytical control, quality control that we always say. So that is most important, on which physicians depends, and then only they will be able to diagnose. Next is the treatment. So treatment evaluation, obviously it depends upon again on the biochemical reports. So patient का sugar कितना ज़्यादा control हुआ है, accordingly physicians they monitor the drug level, their therapy. So the again the important role that biochemical parameters play is in the treatment evaluation. And next is disease prognosis. Biochemical parameters, they provide a valuable information about the disease prognosis, like high level of certain markers like tropin, cardiac conditions, they indicate the poor diagnosis and the increased risk of adverse outcome. And next important in clinical for this biochemical parameters is the early detection of any diseases. And these biochemical tests, they facilitate the early detection, timely intervention, they improve the patient's outcome. And regular screening for some conditions like hypertension, diabetes, and various renal diseases can help in the early diagnosis and the effective management. And these tests are also helps in the health screening, the health checkups to assess an individual's overall health status. And identifying deviations from normal range, they can prompt further investigation and early preventive measures. So this is about the clinical practice in which these biochemical parameters, they are helpful. And from the research point of view, so as I said that the most of the researchers they go for the biochemical parameters to complete their research. So for this purpose, the underlying disease mechanisms can be calculated, can be researched by the help of these biochemical parameters. And the drug development in pharmaceutical research, biochemical parameters, they are critical for evaluating the safety and efficacy of the new drugs. And these can also serve as an indicator of drug response and potential adverse reactions. And large-scale study involving biochemical parameters help researchers to identify the disease trends and patterns in the population, the prevalence of disease, risk factors, and outcome across the different populations. So that we can do with the help of biochemical parameters. And next is by analyzing individual biochemical profiles, researchers can tailor treatment to patients. What it exactly needs, patient specific needs can be assessed by analyzing the biochemical parameters, and by maximizing the therapeutic effect of that particular drug and minimizing the adverse effect of that drug on that specific patient. And lastly, for the disease progression and the regression, longitudinal studies using biochemical parameters, they allow researchers to track the progression or regression of the disease, enabling deeper understanding of the disease trajectories. So next important in biochemical parameters is the sample collection process. Very shortly, I am taking that. So this sample collection is very important for the estimation of any biochemical parameters. And if it is not properly done, so it leads to pre-analytical errors. The patient required for most of the biochemical investigation, fasting sample is needed, especially for the estimation of glucose and lipid profile. Lipid profile may be mainly for the triglycerides. Cholesterol we can calculate even without, if the patient is not in the fasting state. But for glucose and rest of the lipid profile, we need the fasting scan. So we all of us know how to take the sample. Most of the PGs, they are practicing that by cleaning the skin with the antiseptic and from the vein and collect the sample as far as possible. It's rather, I should say, it's mandatory that health professionals, while taking the sample, if they are taking the sample from the admitted patient on which IV fluids are going on, so requesting all the PG students, the most common is a mistake that they do, that they collect the sample from the same vein in which IV fluid is going on. So don't collect the sample from the intracath that is there for the patient, and label the tubes properly and send for the laboratory, and specific tubes for specific biochemical parameters, they are there. And after that, blood samples, they are processed and to measure the biochemical parameters. In the sample collection, the precautions that one should take is the separation of the serum properly. First of all, collection of the sample, and after that, while after collecting the sample, putting that sample into the appropriate bulb with, after removing the needle. If you put the sample with the help of needle only, then the chances of hemolyzed sample will be there and you will not get the correct report. Then you will start blaming the laboratory, ये report इनकी बराबर नहीं आती. So this is usually at the level of PG students कि आपको sample अच्छे से collect करना. It's a mandatory part. That is another session that we can conduct later on. And in blood biochemistry test, that parameters that we estimate, they indicate the organ functions, functioning of the various organs like liver, kidney, whether they are properly functioning or not. And so the biochemical tests, they are organized into profiles specifying the specific organs. So basic biochemistry includes glucose, urea, creatinine. So all these parameters, they are combined into the regarding the specific organ or the disease. So the basic profiles that usually we do in the biochemistry, they are the diabetic profile, lipid profile, kidney profile, liver profile or hepatic profile, bone profile, cardiac profile, and the various liver enzyme that is called as a liver function test. So in liver function test, the mainly it is the ALT and AST. The range of normal range is usually below and 35 units per liter, and for alkaline phosphatase it should be below than 120 units per liter. So from amongst these profiles, we'll go in brief one profile. So we'll start with the diabetes. So it's a diagnostic test for the diabetes. So for diabetes, what we do in biochemistry is the oral glucose. Glucose we estimate, fasting post meal, all of you know that. So along with the fasting and post meal glucose, it is oral glucose tolerance test. It is glycosylated hemoglobin, HbA1c bolte hain jisko. The others, they are the specialized tests that we usually don't perform for the diabetic profile unless until it is highly recommended. So the another test that to complete the profile, it is glycated albumin, fructosamine, insulin, proinsulin assays, and the C-peptide assays. So now basically for the diabetic profile, it is the blood glucose that we estimate, and the method for the estimation of blood glucose is God code bolte, it is glucose oxidase per oxidase method, and the normal value fasting blood glucose, it is 70 to 110 milligram percent or 110 milligram per 100 DL. Post meal blood glucose up to 140 milligram. And in some books, the units are millimoles per liter, but in our country, the mostly values we refer in milligrams per DL. But SI unit is millimoles per liter. And the clinical condition that occur because of the alteration in these blood glucose level. If there is increased blood glucose level, the term is called as hyperglycemia. And that hyperglycemia, it can be because of the most commonest cause of hyperglycemia is diabetes mellitus. And the other hormones that can also lead to increase in the blood glucose level, they are hyperadrenalism and hyperpituitarism. The next is hypoglycemia. Obviously, it is a decreased blood glucose levels. And this decrease, the most commonest cause of hypoglycemia, as I always say, it is the insulin administration. If there is increased dose, to theek hai, but even if the person who is on insulin, अगर उसने उसके बाद खाना नहीं खाया तो that patient lands into hypoglycemia. So from my point of view, the most commonest cause of hypoglycemia is insulin treatment. And another is if there is the tumor of the beta cells, that is there. The next important for the diabetic profile is glucose tolerance test. What is this glucose tolerance test? It is the individual's response to oral glucose load. And this test is used to assess the ability of body to utilize the glucose. Classical test में पहले क्या करते थे? We used to take 6 samples, one fasting at 0 and 5 samples collected at the interval of 30 minutes. 30 minutes and post meal, after post meal. And that becomes total 6 samples of the blood and urine each. But now the modified form of GT, because it's difficult for patient to give the 6 samples in a day. So now the modified form of that is that we are doing, that is called as glucose challenge test. It is mainly, it is the, in this test, it is the fasting glucose that we are estimating, and also the 2-hour sample, which is called as post-meal blood glucose. In that, 75 grams of glucose is administered to the patient orally, and 2-hour sample is collected, and that is called as glucose challenge test. In this, only 2 samples of the blood and urine will be collected. So this is the modern or the glucose challenge test. This is called as. So after estimating this glucose, there will be 3 types of curves that will be obtained from the glucose tolerance curve. So these are the normal glucose tolerance curve, decreased glucose tolerance, and increased glucose tolerance curves. Decreased glucose tolerance curves, it occurs in the diabetes mellitus. So it is one of the commonest cause of hyperglycemia. So there will be a decreased glucose tolerance, and in another conditions like hyperthyroidism, hyperpituitarism, and hyperadrenaline, other hormones, if they affect, they also lead to increased level of blood sugar, leading to decreased glucose tolerance. And increased glucose tolerance, the effects will be, it can be because of hypothyroidism, hyperadrenalism, and hypopituitarism. This is the curve, all 3 type of curves. In green one, it's a normal. You can see that that dotted line, it is indicating the renal threshold for the glucose. Every biochemical parameter has a renal threshold. For blood glucose, it is 180 milligram per dl. Normally, what happens after at 0, it is in the fasting phase, and after meal, 1 hour of the post meal, you can see the peak of the post blood sugar level is there, but it is below the renal threshold, means it is below 180. It is around 140. It is around 140, and after that it is touching the baseline. It is touching the baseline, reaching below 100. It is around 80. But what happens in case of diabetes mellitus? Your fasting is already around 140, and the post meal blood sugar at 1 hour, it is around 230, 240, more than 200 and more than the renal threshold. And after 1 hour, it is coming down, but it is not touching the baseline, and it is above the renal threshold. So these patients, they are labeled as diabetic patients. Here, that is called as diminished blood glucose tolerance, which occurring in the diabetes mellitus and other endocrine hyperactivities. And third one is when there is increased glucose tolerance. Here, the renal threshold से बहुत नीचे है, the value is around 50-60 की range में it is. So here it is the increased glucose tolerance, which is due to endocrine hypoactivity. So these are the WHO criteria for oral glucose tolerance test. On these criteria we can diagnose the patient, whether the patient is diabetic or whether the patient is having impaired glucose tolerance. For the normal person, the fasting glucose should be less than 110 milligram per dl, and for diabetes it should be more than 126 milligram. Then only you will label it as a diabetic patient. And for impaired glucose tolerance, the fasting levels should be around 110 to 126 milligram per dl. This is the fasting value. And 1 hour after glucose, normal person it should be less than 160 milligram. And for diabetic and impaired glucose, it is not described because we calculate 2 hours after the glucose. And for the normal person, it is 140. And for diabetic, it should be more than 200 milligram. And for impaired glucose tolerance, it is 140 to 199 milligram per kilo. So this is the WHO criteria for the diagnosis of the diabetes. So this GTT, the significance of GTT is that it is not necessary in symptomatic or in known case of diabetic patient. If patient is already having diabetes, so there is no point in calculating this GTT and unnecessarily give trouble to the patient. And it is most important in the investigations of asymptomatic hyperglycemia or glycosuria, such as renal glycosuria and alimentary glycosuria. And also it provides the information of the endocrine dysfunctions and useful in recognizing milder cases of the diabetes. The another important parameter, so this is about the GTT. The another important parameter that helps us to for the diagnosis and the monitoring of the diabetes and also for the treatment purpose, that is glycated hemoglobin. इसको HbA1c भी बोलते हैं. Glycosylated hemoglobin, this is also known as a glycosylated hemoglobin. So what is this glycated hemoglobin? And this glycated hemoglobin, it covers a number of chemically different modifications resulting from non-enzymatically and irreversible binding of the sugar to different amino groups in the hemoglobin. So these blue ones, they are the sugar molecules that are binding with the RBCs. If the binding is more, the HbA1c levels will be more. It means if a patient is diabetic, so this more binding of the sugar molecules with the hemoglobin, so more values will be there. So hemoglobin plus glucose, it will form one intermediate product, and finally that is called as glycated hemoglobin. And this glycated hemoglobin or HbA1c, it gives information about the average blood glucose concentration over a respective period of time. And it reflects the mean glucose concentration. The normal range for the glycosylated hemoglobin, it is the less than 5% of the hemoglobin. And this is very important to know about the glycosylated hemoglobin, is that usually ये बोलते हैं कि glycosylated hemoglobin, it measures the तुम्हारा 3 महीने का blood sugar level बताता है कि तुमने क्या खाया. But see, the 50% of HbA1c values, they represent the blood glucose level of preceding 30 days. मतलब एक महीने की maximum value वो 1 month की बताता है HbA1c. Then 40% from the preceding 31 to 90 days, and only 10% from the period between 91 to 120 days. So this is the pattern. So last 1 month ka is 50%. That is the value that is given by this glycosylated hemoglobin. And it is not affected by diet, exercise, and insulin on the test result. And this is more informative than the fasting and the post meal. कैसा होता है, when a patient is diabetic, उसको मालूम है आज अपने को blood sugar check करना है, तो वो 3 दिन पहले से खाना पीना बंद कर देता है ताकि at least fasting normal आ जाए, post meal भी थोड़ा सा ठीक आ जाए. But this glycosylated hemoglobin tells us all this 3 महीने में उसने कहाँ गया, क्या किया. So that's why we always say that this glycosylated hemoglobin is more informative comparative to your fasting and the post meal values. So that's why it's having importance. Another important thing that we should know about this is the how to deal with the discordance. Means suppose so many people, they are identified as having diabetes using HbA1c, will not be identified as having diabetes by traditional glucose criteria, or ulta uska vice versa bhi ho sakta hai. By glucose criteria, they are diabetic, but if we estimate HbA1c, they are non-diabetic. So how to deal with such type of discordance? होता है ऐसा बहुत बार. HbA1c is on the higher side and fasting and post meal, they are on the normal side. So to deal with this, when the results of more than one test are available, suppose we have fasting, post meal, HbA1c and 75 grams of glucose tolerance test, then the results are discordant. If they are not, all the 4 tests, they are not matching with each other, then the test whose result is above the diagnostic cut point, then it should be repeated and the diagnosis should be made on the basis of the repeat test. I think I am clear. So how to deal with the discordance is the जो भी test की value ज़्यादा आएगी, again repeat that test and diagnosis should be made on the basis of that repeat test. So this is the way to deal with the discordance. If there is any confusion, if there is any controversy. So for HbA1c, if the HbA1c it is 7%, then we can say patient is having good diabetes, good control on the diabetes. And if it is 10% HbA1c, which is not at all acceptable, poorly controlled patient, and more than 30% is the very poorly controlled HbA1c, very poorly controlled sugar level. So this HbA1c helps to monitor the patient compliance. So this HbA1c predict the development and progression of microvascular complication that can happen because of the increased sugar level. And also for the therapeutic option, if patients are on the oral hypoglycemic drugs, then when to shift to the patient to the insulin. So all these will be with the help of HbA1c only. Level of HbA1c पहले उसका estimate करते हैं, check करते हैं, then only there should be shifting of the drug from oral to insulin or further. Beta transplantation, it is not that easy. Usually patient take the oral and the insulin or combination of the both drugs depending upon the patient's HbA1c level. And also used for the diagnosis of the diabetes, that is primary criteria. So at what intervals we should go for HbA1c determination? So type 1 diabetes mellitus, if it is patient is having controlled this thing, minimal or conventional therapy पे है और उसका control चल रहा है तो 4 times a year. And if it is on the intensified therapy, बहुत ज़्यादा insulin की doses है, uncontrolled diabetes mellitus है, तो we can go for every 1 to 2 months. Otherwise, usually ये बोलते हैं कि you should wait for minimum 3 to 4 months for the estimation of HbA1c. And for diabetic type 2 diabetes mellitus, twice a year in the stable patients. My slides are moving.
Yes, they are moving. Yes.
Okay, then so this is about the diabetic profile. The next in the profile is the lipid profile. So the most important, these are related. So patient is having diabetic, so patient needs the lipid profile also. So the major lipids that we measure in the plasma, they are the fatty acids, triglycerides, cholesterol, and the phospholipids. And these laboratories, they offer many tests for the lipid disorders, and the most important one is the lipid profile, which include the panel of the testes as the triglycerides, cholesterol, and also in the form of lipoprotein cholesterol molecule, which are LDL and HDL, that is low density lipoprotein cholesterol and high density lipoprotein cholesterol. And the clinical significance is that these cholesterol and triglycerides, they are the essential components of the body, and they attract clinical attention when they are present in the normal concentration. And increase or decrease level of, rather I should say, of any biomolecule, it depends upon the either in the synthesis, abnormalities in the synthesis, degradation, and transport. These are the 3 basic criteria. If there is alteration in all these 3, that leads to abnormality in any of the biochemical parameters. So same is with the lipid profile also. And increase or decrease plasma lipoproteins, increase plasma lipoprotein levels, it is called as hyperlipoproteinemia, and decrease, it is called as hypolipoproteinemia. And what is hyperlipidemia? Hyperlipidemia, it is the elevated level of any or all lipids or lipoproteins in the blood. So it is an overall term, and specifically if it is a lipoproteins, it is the either hyperlipoproteinemias or hyperlipoproteinemias. And elevated lipids are mainly, these are the cholesterols, which are, it is the cholesterol that is mainly responsible for the pathogenesis of atherosclerosis. So these are the biochemical tests that we do in the lipid profile, which are ordered to determine the risk of heart diseases. So total lipids, total cholesterol, the range should be in between 150 to 200, LDL 80 to 150, HDL 30 to 60. So the triglyceride 75 to 150. These are the 4-5 parameters that are important in the lipid profile. So as I said, the cholesterol level, it should be below 200 milligram. 200 milligram per DL for the low risk of heart diseases, and borderline if it is 240 milligram or higher. High values are high, then risk of heart disease is more. And for estimation of blood cholesterol, fasting sample is not mandate, but for other lipids, it's mandate. And if cholesterol, it is not affected by single meal. Achada oil ka kha liya, tel ka kha liya, so your cholesterol level will be increased. It's not like that. But it's the eating pattern that affects the level of the cholesterol. So we can shift from high fat diet to low fat diet for several weeks, then only there will be controlled level of the cholesterol. And in few diseases and in few conditions, there is increase in the cholesterol level, like during pregnancy. And some drugs are also known to increase the cholesterol levels, like steroids, beta blockers, epinephrines, oral contraceptives, and the vitamin D. The next in the lipid profile is triglycerides. For this, you need fasting cycle. 12 hours fasting is necessary for the calculation of the triglyceride levels, because its levels are affected by the meals. Fatty meal, high carbohydrate meal, they increase the level of the triglycerides. And for good for the fatty liver, the triglyceride level should be less than 150 milligram per day. And hypertriglyceridemia, if it is there, it increases the risk for pancreatitis, and also it is associated with various diseases, mainly the hepatomegaly and the splenomegaly. That is the commonest one. LDL, it is called as bad cholesterol. Why it is called as bad cholesterol? Because it carries cholesterol from liver to the organ, liver to blood, and then to organ. So that's why it is called as a bad cholesterol, and it is having very low protein content and more in the cholesterol. So, and cholesterol has a tendency to stick to the walls of the blood vessel, and that's why it is responsible for the atherosclerosis and the myocardial infarction. So plaque formation is there. So this is the pathogenesis of the atherosclerosis, and plaque formation is there, clot formation is there, and that leads to narrowing of the arteries, and ultimately patients, they are prone for the heart attack or the stroke. So if patient is diabetic or having the heart disease, he should maintain the LDL level less than 100. And if 2 or more risk factors are there, then it should be less than 130, and 0 or 1 risk factor, then thoda sa zyada bhi raha to bhi chalta hai, but still it should be less than 160 milligram per day. Contrast to this LDL, we have another acha wala parameter which is called as HDL, that is high density lipoprotein, which is called as the good cholesterol, and it LDL carry cholesterol from liver to organ, and vice versa is the role of HDL. That's why it's called a good cholesterol, where it carry cholesterol from organs and blood to liver to get rid of it, and it removes the excess cholesterol from the tissues, and it cleans the blood. And high HDL is good. If it is there, it lowers the risk of the heart diseases. Less than 40 is not so good. So maintain the level of HDL between 60 milligram or more. So in nutshell, measurement of only serum cholesterol is not sufficient to assess the cardiovascular diseases. So we have list of parameters that are equally important, and for the estimation of this, except cholesterol, 12-hour fasting is needed. The next profile is liver function test. Liver, it's a huge organ. बहुत बड़ा है इसका. So accordingly, functions of liver are also much. So based on the functions of the liver, biochemical tests, they are classified. So based on the excretory function of the liver, we have bilirubin. In that, total conjugated and unconjugated bilirubin is there. And from the urine, bile pigments, bile salts, and urobilinogen, they are there. And from the liver enzymes, it's the ALT, that is alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase, and gamma glutamyl transpeptidase. These are the enzymes that we estimate for the whether the liver is working properly or not. That is for the liver function, to estimate the liver functions. And next is as we know that liver is known as a synthetic organ. बहुत सारी synthesis होती हैं उसमें. And also for the detoxification purpose, the function of liver is there. So the test for the synthetic function of liver is they are the total protein, serum albumin, globulin Ag ratio, and prothrombin time is there. And the specialized tests that are used to detect the liver function, they are the levels of the ceruloplasmin, ferritin, alpha-1 antitrypsin, and alpha fetoproteins. These are the liver function tests. So this was the classification that is based on the functions of the liver. One classification that usually we do as a clinician, that we usually recommend as a clinician, that is markers of the liver dysfunction, which include serum bilirubin, urine में bile pigment, bile salt and urobilinogen, total proteins, prothrombin, and blood ammonia. And markers of hepatocellular injuries, the enzymes, then if there is some alteration in the level of the enzyme, in the ALT, AST or ALP, it indicates the hepatocellular injury. And ALP, if it is alteration in the level of ALP and gamma GTT, gamma glutamyl transpeptidase बोलते हैं उसको, transferases भी बोलते हैं, they indicate the obstruction to the flow of bile. So they are called as markers of cholestasis. So these are the clinical classification of the liver function test. So it is one and the same thing. We can recommend it in any. So this is the interpretation part of the liver function test. So we divide it into three parts. If there is something happening at the before the level of the liver, so that are the pre-hepatic conditions. If it is at the level of liver, it is hepatic condition, and if it is at the level of beyond this liver, then they are the post-hepatic causes of the liver dysfunction. So you can see in all three, there is increase in the level of serum bilirubin, but in post-hepatic, there is increased level of serum bilirubin levels. And the type of bilirubin that is increasing in all the three conditions. In pre-hepatic, there is increased level of unconjugated bilirubin, and in post-hepatic, it is the increased level of conjugated bilirubin, because in this type of condition, conjugation is normal. Everything is normal at the level of liver. Whatever is the pathology, it is beyond the liver. So conjugation is occurring properly. So that's why there is increased level of conjugated bilirubin. Urobilinogen, it will be increased in the pre-hepatic, and hepatic may either it's normal or increased, and in case of post-hepatic, because there is obstruction, bilirubin will not be converted into urobilinogen and the stercobilinogen. So there is decreased level of post-hepatic bilirubin. Actually, ये जो cycle, and if you know how there is formation of bilirubin occurs and then conjugation, all comes under the pathogenesis. So it's a very good cycle, heme degradation जो बोलते हैं हम. So all this interpretation is based on that. So it's simple mathematics. Post-hepatic में there is decreased urobilinogen because of the obstruction. There is no conversion of conjugated bilirubin to urobilinogen. Same is with the stock of bilinogen. Pre-hepatic में it is increased, and hepatic में or post-hepatic में तो either it is completely absent or it is decreased. So that's why in hepatic and post-hepatic, patient complains of the clay-colored stool, because the color of the stool is because of the stercobilinogen or stercobilirubin. And amongst the enzyme activities,
listen.
Amongst the enzymatic activities, it is the ALT.
किती झालेच आहे? अच्छा, बाकीच्यांच्या झाल्या.
Amongst the, should I continue?
I request all others to unmute their mics, please. Only our guest speaker will talk. You can carry on, madam.
Yeah, sorry for the interruption. Amongst the enzymatic activities, it is the ALT. That is, these are the transaminase enzyme. Amongst that, SGPT, which is called as ALT, specific for the liver, and AST, SGOT also indicates the enzyme activity, indicates the enzymatic activities of the liver, but they also increase in the cardiac diseases also. So if there is alteration in the liver due to any pathological condition, there will be increased level of the transaminase enzyme. You can see in the hepatic condition, there is increased ALT levels. And in the post-hepatic, they are increased, but not to that extent. And reverse is the case of the alkaline phosphatase. There is increase in the level of alkaline phosphatase in the hepatic type of conditions, but in post-hepatic, because it indicates the obstruction, increased level of alkaline phosphatase, it is more in the post-hepatic type of liver disease because of the obstruction. Same is with the 5' nucleotidase, it is also indicating the obstruction. And gamma glutamyl transferases, it indicates the hepatic type of pathology. And this is mainly the alcoholic cirrhosis, in which there will be increase in the hepatic transferases. So this is the interpretation of the enzymatic activities of the liver. So next, moving to the next profile, that is renal function test. This renal function test is again, it is divided into the, depending upon the whether it is assessing the glomerular function or whether it is assessing the tubular functions. So for assessing glomerular functions, the clearance tests are there, which are creatinine clearance, urea clearance, and these clearance tests are used to measure the glomerular filtration rate. So by measuring glomerular filtration rate, we are assessing the glomerular function, whether it's normal or is there any abnormality. So like if we measure the protein urea, which reflects the glomerular permeability. Protein matlab leak ho raha hai, matlab there is something wrong with the glomerulus. So that's why it is allowing protein to move. And tubular function mein concentrating and dilution tests are there. Urine concentration and dilution tests are there, which we hardly perform. Analysis of blood and serum mein, it's the estimation of blood urea, serum creatinine, proteins and electrolytes. They are often used to assess the renal function. And complete urine analysis from volume, pH, specific gravity, and urine ka sugar, protein, and pus cells, all these come under the complete urine analysis to assess the kidney functions. So as I said, the glomerular functions, they are used, the tests that are used to assess glomerular functions, they measure the GFR, glomerular filtration rate, and these are the clearance tests. And clearance is what it is defined as the volume of the plasma that would be completely cleared of that substance per minute. So volume of that substance and the time. So that's why it is expressed as ml per minute. So blood urea level, it's a 10 to 50 milligram per 100 ml of blood. So the normal range is 10 to 50 milligram. And significance, again, these blood urea levels, we can, interpretation part is usually pre-renal, renal, and post-renal. So the mostly it is the kidney diseases in which there is increase in the blood urea nitrogen bolte hain, because blood urea, after calculating blood urea, we calculate blood urea nitrogen from the blood urea values. So that's why it is written here as increase in the blood urea nitrogen, and it is increased in the various kidney diseases. Kidney diseases like chronic nephritis, glomerulonephritis, nephrotic syndrome. So lot many diseases are there in which there is increase in the blood urea nitrogen. Other than that, shock, if it is there, ultimately cause that shock leads to the organ failure and increase in the level of the urea. Dehydration, if it is there, diabetes and acute myocardial infarction. And decreased level of urea usually occurs in the liver failure, because liver is the tissue where there is synthesis of urea occurring, and detoxification also occurs. And it is the impaired absorption and poor filtration that is increased outflow. That is the apparent decrease in the urea levels. Creatinine is more significant to estimate the renal function rather than the blood urea, because creatinine is the substance that is neither secreted nor excreted. It is neither secreted nor absorbed from the kidneys. Matlab, it is not affected by any kind of diet. So that's why this is more useful biomarker to assess the kidney function test. And it is also a marker of glomerular filtration rate, creatinine clearance, even blood urea also, but more specific is creatinine clearance. From the creatinine clearance, the more specific is inulin clearance. But as it is interventional methodology, so we usually stick on this creatinine clearance. And for the creatinine, the range is very less. It is 0.5 to 1.2 if we combine both male and the female. And creatinine levels, again, they increase in the mainly in the kidney diseases, in the chronic diseases. If the renal failure is there, then only alteration of the creatinine values occur. But if there is reduced muscle mass, then it may lead to the lower values in case of muscular dystrophies or myopathies. Next profile is the cardiac profile. It is the cardiac profile. These are the enzymes in the myocardial infarction. So the enzymes that are responsible for the estimation to know that the patient is having infarct. Here in this case, what is important is the time. Suppose the marker for the estimation of the myocardial infarction or cardiac profile, we can say it is the myoglobin, trop I bolte, troponin I, trop T, CKMB, LDH1 or AST or SGO. So if you see, it is a time that is important for these markers. Myoglobin, it releases within 1 to 4 hours of the MI, of the myocardial infarction. If the patient is suffering from the MI, the most earliest one to raise is the myoglobin. And this myoglobin, it reaches the peak within 4 to 6 hours and it comes to normal within 20 to 24 hours. Suppose patient को MI पहले ही होके चुका है, एक दिन हो गया, patient को पता नहीं चला, if it is a silent MI, so you may find that myoglobin levels, they are negative. So in that case, the comes the role of other enzymes. So next is the troponin I. Trop I बोलते हैं उसको. It increases after 4 to 10 hours and returns to normal after 5 to 9 days. बहुत टाइम के बाद वो कम होता है, तब तक कि पेशेंट हॉस्पिटल पहुंच जाए. Trop T तो और उसके भी बाद में बढ़ता है, तो return time is almost start from 50. CKMB, the another that is important is PKMB. CK has 3 isoenzyme. The specific one for the heart is it is the CPKMB. This is the second isoenzyme of creatine kinase, and it start increasing from 3 to 6 hours. Peak is 18 to 24 hours and returns to normal within 24 to 48 hours. Next is LDH. LDH1 specifically, because again it is having 5 isoenzymes. So specific for heart is the LDH1, which start increasing after 2 days and returns to normal after 10 to 15 days. SGOT is 24 to 36 hours and 44 to 6 hours. So important one is trop I. Trop I is the one, and myoglobin and CKMB. Patient ko laya immediately that we can, then we should go for first these 3: CPKMB, trop I and myoglobin. Next is the electrolytes. In electrolytes, mainly the electrolytes that usually we do, they are the sodium, potassium, calcium. So range is 135-40, 3.5 to 5, and 8.5 to 10. So there can be alteration of the electrolyte because of the many causes. Increased level of sodium, hypernatremia, and decreases hyponatremia. So accordingly, other conditions are also there. But the important in this case is the sample collection is collected in this. They are collected in specialized tube. Usually, unka diprenized green top hota hai for sodium and potassium, and for the calcium they are the lavender top tube. And for the calcium, always ask your PG student that go for the fresh tube, because if there is calcium deposit already in the used one tube, so levels may, because it is very sensitive electrolyte calcium. So your results may be, you may find the altered results. The another important in the electrolyte, arterial blood gas, in which we measure pH, partial pressure of carbon dioxide and bicarbonate ions. So these are used to measure to know whether patient is having any kind of alkalosis or acidosis, whether it is respiratory or whether it is metabolic. If it is respiratory, then alteration will be in the alkalosis. Obviously, there will be increased in the pH level, and if it is acidosis, there will be decreased in the pH level. And if it is alkalosis, the level will be, affected level will be of partial pressure of carbon dioxide, and same is for the respiratory acidosis also. And in case of metabolic, either alkalosis or acidosis, it is the alteration in the level of the bicarbonate that is there. So that is the difference between respiratory and the metabolic. Respiratory is related with the partial pressure of carbon dioxide, and metabolic is related with the bicarbonate ion levels, whether it is acidosis and alkalosis levels will be increased or decreased on the basis of that. The next is the hormones. The Amongst the hormone, the important one is the thyroid function test. Long list is there for the diagnosis of the thyroid function test, but the commonest one that we usually perform in the laboratories, they are the TSH level, thyroid stimulating hormone level, serum total or free T3 and T4. These are the two things that usually we perform to assess the thyroid function test. To complete the list, we have TRH, that is thyroid releasing hormone stimulation or thyroid releasing hormone response test, thyroid hormone binding proteins. If everything is normal, still patient is having low or thyroid or high thyroid levels, it means something is wrong with the binding proteins. And we can go for the radioactive iodine uptake and thyroid scanning, thyroid ultrasound, and fine needle thyroid biopsy depending on the condition. And these thyroid estimations that we do in TSH, this thyroid disorder, they are of two types, primary and secondary. And in primary, the defect is basically in the thyroid gland. And in the secondary, it is the defect in the above the thyroid gland, either in the hypothalamus or in the pituitary gland. And if we estimate TSH level, so it will differentiate between these two types of thyroid disorder, whether it's the primary thyroid or whether it is the secondary thyroid disorder. So in case of primary hypothyroidism, primary matlab it is related with the thyroid gland. So primary hypothyroidism hai, so TSH levels will be elevated. See, the pattern is reversed. Hypothyroidism or hyperthyroidism, it is labeled on the basis of level of T3 and T4. Although the important parameter that is considered is TSH, but the hypo and hyper is labeled from the values of T3 and T4. Primary hypothyroidism, TSH levels elevated because of the lack of the feedback, and primary mein hyperthyroidism mein TSH levels decreased. And reverse is the case of the secondary hypothyroidism, secondary hypo or hyperthyroidism. And estimation of T4 and T3 we can do by the radioimmunoassay and by the ELISA also. So as I said, the pattern is reverse and the patient labeled as hyper and hyper on the basis of this T4 and T3 level, decreased in hypo and increased in the hyperthyroidism. That is the case in case of T4 and T3. Thyroid hormones, they usually occur in the bound form, protein bound and the free form. And these hormones, they induce biological action in free form, and increase or decrease in the level provide more accurate diagnosis of the thyroid disease. So usually it is advisable to do the free T3, T4 rather than the simply the total T3, T4, which is the protein bound forms. But in sometimes laboratories, it is this facility is not available to estimate the free T3, T4. So we go for the total T3, T4 levels. So these are the normal values. T3, T4 in the nanograms and total thyroxine in milligrams and TSH in the micro units. Other thyroid functions that can be there, BMR, which will be increased in hyperthyroidism, and BMR low in the hypo, serum cholesterol. But we usually do this for the, don't do for this for the thyroid function. It is a T3, T4, which can be free or total, and the TSH levels that are important for the assessment of thyroid function test. Along with these hormone assays, thyroid function test, other hormone assays that we usually do in our laboratories, they are for the infertility parameters. They are the reproductive hormones like LH, that is luteinizing hormone, and which plays a main role in the menstrual cycle and ovulation in the woman. And follicle stimulating hormone that also measure to help the regulation of the menstrual cycle. So they have different levels, values in the different phases. Like if you see in the follicular phase of menstrual cycle, the level is less, and mid cycle mein level is at the peak, and the luteal phase mein again there is in the level of the hormones. So they have importance in the to see the patient is having some issue with the reproduction. Estradiol, female hormone, and its level decreases in the postmenopausal phases, and progesterone during the menstrual cycle and the pregnancy, and testosterone, male sex hormone, and along with that adrenal hormones are also there. So these we not perform regularly, but these all are the specialized tests. And इनमें important है आजकल DHEA करते हैं, which contribute the production of other hormones, including the testosterone and the estrogen. So these are specialized tests, growth hormone test, and last is the insulin. We know that for the blood sugar regulation and the diabetes mellitus. Prolactin again is very important, which stimulate the milk production and also affect the reproductive health in both men and for the women. So non-pregnant women, it should be less than 25 nanograms per minute. And for the pregnant woman, it is 80 to 400. बढ़ जाता है एकदम से. Parathyroid hormone, again it is important from amongst all other hormones for the regulation of calcium and the phosphate. So this is the list of the hormone acids. These are all our specialties. So the last, we'll go for the tumor markers. Again, these are the biochemical tests or markers that helps in the detection of the tumors, presence of the tumor in the body, and they are called as tumor marker, and they are employed to detect the presence of the cancer in the early stages. And but negative tumor marker result doesn't mean that there is no tumor, so it doesn't exclude the diagnosis. So the applications of tumor marker, again for the screening, to support the diagnosis, for the prognosis. The important here, it is the prognosis of the disease, mainly for the cancer patient. So it indicates the tumor load for the localization of the tumor, and next is the monitoring the response to therapy. That also is the important thing for in the application of the tumor markers. And the important tumor markers, they are the CA, PSA, immunoglobulins, hormones, and enzymes. And amongst these are the important tumor markers. Like alpha fetoprotein, it is used for the as a tumor marker for the cancers of the liver, carcinoembryonic antigen for the cancers of the colon, lung, and breast, CA125 for the ovarian cancer, PSA, prostate specific antigen for the prostate cancer, and alkaline phosphatase as an enzyme which is specific for having isoenzyme in the liver and in the bone. So it is used for the as a tumor marker for bone and the liver disease. And lastly HCG, which is a tumor marker for the choriocarcinoma. So this is all about the interpretation of biochemical parameters from my side. Thank you so much, all the participants, for patient listening. Thank you, everyone. Thank you. Thank you.
Thank you so much, ma'am, for enlightening us with your elaborative, very informative lecture. Thank you so much. It's time for the question and answer session. If anyone has any questions or any doubts, they can ask.
Hello.
Yes, sir.
For renal function test, we use through serum, but why it is called blood urea and serum creatinine?
Sir, we can label if specifically any kind of blood investigation. We can use blood, but specifically if we want to use, जैसे हम बोलते हैं blood sugar, पर blood में the specific word is plasma glucose. Because what we are measuring in the blood sugar, it is the plasma glucose. Same is with the question that you asked. So it can be blood sugar, it can be blood urea, it can be plasma urea, it can be serum urea. So these are the estimation that we can use in the whole blood also, or in the plasma also, or in the serum also. So that's why we can call it as a blood sugar, blood urea, plasma serum. So that is not the issue. So it is the different names that are given to this. But to be very specific, it is serum urea, serum creatinine, and plasma urea, because we are using plasma for the estimation of the urea and serum for the estimation of the creatinine. That's why.
Okay, thank you.
It is only the separation of the blood components.
Yes.
Ma'am, there is a in chat box. Vivek Nemade sir wants some book names for the biochemical and immunoassay parameters.
Am I audible?
Yes, yes, ma'am. You are audible.
Vivek, sir, there are many books available specifically for this biochemical parameter, but TEEDS is the book which is the best one for this biochemical parameters, where you will find out all this interpretation as well as the immunoassays and other information also about the biochemical parameters. Very good book for this. TEEDS.
TEEDS, madam. TEEDS.
Yes. और अगर simplified form में जाना है आपको, तो हमारे
हाँ.
एमबीबीएस के स्टूडेंट्स के लिए जो हम रिकमेंड करते हैं अभी कॉम्पिटेंसी बेस्ड मेडिकल एजुकेशन में प्रैक्टिकल की बुक्स आई हैं, सो दैट इज अ सिंप्लीफाइड वर्जन, मतलब नॉट दैट इलैबोरेटिव, बट फॉर पोस्ट ग्रेजुएट्स एंड फॉर द फैकल्टी एंड फॉर द प्रैक्टिशनर्स TEEDS is the best one.
TEEDS is the best. Okay. Thank you. Thank you.
Any other questions? I would like to request Dr. Amit Shirke sir for chairperson's remark. Over to you, sir.
Good afternoon, everyone. Am I audible?
Yes, sir. Yes, sir.
Yeah. Thank you, ma'am, for giving very informative lecture. Almost all the biochemical parameters were very well covered with their interpretation also. It was very informative, and thank you once again for sharing the valuable knowledge from your side.
Thank you, sir. Thank you so much. Thank you for giving me this opportunity. Thank you so much, everyone, organizing team, participants. Thank you for your comments in the chat box. Thank you so much. So I am stopping the session here, hoping there is no more questions.
Yeah, I thought so. There is no more questions, but ma'am, I think it's a time for vote of thanks, and for that, I would like to request Dr. Ashwini Khandekar, madam, to deliver the vote of thanks.
Namaste, everyone. As all good things come to an end in life, so is the today's webinar. On behalf of our Rog Nidan Vikruti Vignan PG Association, I, Dr. Ashwini Mangesh, take this opportunity to propose the vote of thanks to those who have directly and indirectly contributed to this webinar on interpretation of biochemical tests organized by our RVPG Association. At the outset, I thank our chief guest and today's enthusiastic speaker, Dr. Manju Chandan Khede ma'am. We are really enlightened with your knowledge and presence. I also thankful to Dr. Amit Shirke sir for today's session as chairperson. We are thankful to our honorable founder, President Dr. Subhash Baghe sir and founder secretary Dr. Santosh Chauhan sir for their motivation. I would like to thank our treasurer Dr. Vaishali Ganorkar ma'am for her enthusiastic support. A special thanks to Dr. Ankush Dikondwar sir and organizing committee for their unflinching support and coordination. Finally, our heartfelt thanks to all participants who attended today's webinar with active participation. With these warm words and a kind message, we will end today's webinar here. Thank you all. Jai Hind.